Couple of things to talk about today. I will go into a little bit about the recent Marburg outbreak that has started in Equatorial Guinea, and then we'll talk a little more about the COVID situation and what appears to be the new normal, and again, why it just doesn't add up. So let's start with the breaking news out of Sub-Saharan Africa, the latest filovirus outbreak. As you remember, we just about a month ago had the declaration of all clear from Uganda for their Ebola Sudan virus outbreak, and now we have a new one following close on its heels. This announcement came out yesterday from the World Health Organization announcing the first Marburg virus disease outbreak affecting the country of Equatorial Guinea. So far, what we know, 9 deaths with, I think, 16 suspected cases. So what is Marburg virus? Marburg virus is a filovirus, so it's a cousin of Ebola virus. It causes a disease with very similar clinical presentations. Like Ebola, it is transmitted person to person by close contact, primarily with people who are quite ill. It is a significant risk for infection in hospital settings to healthcare workers and also to other patients, and also in funeral ceremonies and other instances where folks are handling human remains that may have very high burdens of virus. It does appear that at least this first cluster of cases that has been detected in Equatorial Guinea, it was in people who attended a funeral ceremony. It had been previously thought that Marburg virus was slightly less severe than Ebola in terms of case fatality rates, but in outbreaks over the last 20 years, that's really proven not to be the case. So the largest outbreak to date occurred in 2004 and 5 in Uige, Angola, which is not terribly far away from Equatorial Guinea. And that outbreak resulted in over 370 cases and had a case fatality rate of 88%. So really in the ballpark of severity and fatality that we see in Ebola. Marburg virus had most frequently been found in the region of Uganda and Kenya around Lake Victoria, and most of the outbreaks have occurred there, but the larger outbreaks have occurred in other places, and again, Angola being the site of the largest. More recently, there have been detections of Marburg virus in Ghana and Guinea in West Africa, which is outside of where we thought the epicenter of Marburg reservoirs was. So the virus has a natural reservoir of fruit bats, which has been well established, unlike Ebola, where we still don't really know the natural reservoir. And so it's thought that spillover transmission into humans or other animals occurs from contact with fruit bats or potentially their droppings. So a little bit about Equatorial Guinea, where the outbreak is. You can see on the bottom left that gives you a perspective of location on the continent of Africa. You can see not terribly far from the Democratic Republic of Congo or Angola, where the large Uige outbreak occurred of Marburg. You can see also kind of just below Nigeria and Cameroon, turning the corner in the Gulf of Guinea there. On the right, you can see that the country is geographically somewhat interesting because the capital is on an island that's about 120 miles or so off the coast of the main part of the country of Equatorial Guinea, which is on the African mainland, which is in some ways good because it means the major international airport in Malabo is remote from where the outbreak site is. There is an airport in Bata that has flights to Cameroon and Gabon, but much less well-trafficked than the airport in Malabo. Relatively sparsely populated country, 1.63 million people over a relatively large area. So that's about 100 miles by 100 miles or so, the main part of Equatorial Guinea. As you can see, its human development index is relatively low, so 145th out of 191 countries. Interesting, it does have a lot of oil wealth, but most of that wealth is concentrated in a very small number of individuals, and the majority of Equatorial Guineans, if that's what they call themselves, are quite poor. You can see the arrow points to Kinatem, which is the province where this outbreak is currently located, kind of the northeast corner near the border of Cameroon, which is, again, somewhat good because it's remote from any major airports. I'm not that familiar with this part of Africa. I've not been to this region, but I think the road conditions there are also relatively poor in relation to their development status. And so this is occurring in a rural area, which has a bit more difficulty in travel to more populated areas, which is probably good news in terms of what makes filovirus outbreaks grow larger and become more problematic. Oh, it's about 80 miles from the airport in Bata to where the outbreak is currently located. In some bizarre news about Equatorial Guinea, it has been ruled by the same dictator for over 30 years, whose son is the vice president, and interestingly, just a couple of years ago, had funds seized from him, which are now being used to pay for COVID vaccine delivery. But you can see that among the many things that this gentleman had acquired were a $30 million mansion in Malibu, California, a Ferrari, and a pair of $275,000 jewel-encrusted gloves belonging to Michael Jackson. So an interesting family running the country, which probably is not going to make response any easier. So that's the situation there. We'll keep our eyes on it. Again, some good news and bad news in terms of the outbreak being in a place that does not have the best public health infrastructure, but fortunately somewhat remote and rural, and so potentially less likely to trigger a giant outbreak, but we'll see. So now on to COVID. So this is where we are in terms of our case counts. And if you look at this, everything looks great. And so we're returning to normal and things are great and the disease is endemic and there's no problems. Again, we've talked about why a lot of these data are misleading. And if you really want to look at what the virus burden is in the population, I think now wastewater is really the only way to get an accurate assessment, because it does not depend on people presenting themselves for testing. And you can see by wastewater virus burdens, we are at levels higher than we've seen really at just about any other time other than the Omicron spike, and somewhat lower than what we saw with the BA2 wave and the BA4-5, BQ1 XBB Northeast wave that we just recently recovered from. But what you can also tell is the drop that we've had over the last month or so is really leveled out, and now we're still at a plateau. And we're going to remain, I'm guessing, around that plateau for potentially a while or potentially for a long time. This could be the new normal set point that we're just going to bump up and down around that level. And so you can see this is the recent variant waves that we've experienced and where we've seen spikes. But again, we're at a level equal to what we saw in the Delta outbreak, and I don't know that is going to change all that much. If you look at regional trends, you can see the Northeast, which had kind of that big wave of XBB.1.5 that occurred in December and January, has been trending down for the last month and a half. But now we're seeing upward trends in our area, the Midwest, and also in the South. These are areas of the country where XBB.1.5 has only just recently become the more predominant strain. So we may be seeing a bit of a spike here over the next couple of weeks. But again, I think overall across the country, we're going to see this relative steady level plateau that'll bounce up and down, but won't go way down. In terms of hospitalizations and deaths, on the top right, you can see deaths. We're still hovering around 450,000 to 500,000 deaths 450 to 500 deaths per day. But translated over the course of a year, as you know, that's quite a few deaths. If we remain at that level, that's well over 140,000 deaths in the course of a year. And if that's where we stay, and above 150,000 if we're closer to 500, so we're still well above what we would expect with influenza level mortality over the course of a year. And you can see hospitalizations are starting to turn around as well. So I think again we're kind of at a plateau. We're not going to drop that much in the near future, I don't think. Some interesting data out of the UK recently, which I think illustrates some of these issues in terms of what does the new normal mean and how have we gotten here. So I think I've mentioned this Office of National Statistics ongoing survey that the UK does. It's really one of the only windows we have into true population burden of COVID-19. And it's been going since very early in the pandemic, and it's given us great data. And again, I think there's a lot of parallels between us and the UK that we've pointed out. So just to go a little bit more into detail about this study, again, started early in the pandemic and has been doing fortnightly. I love that term that the English use, every other week, every 2 weeks, surveys of the population in the UK, getting about 180,000 samples over the course of those 2 week periods across all of the UK. You can see obviously most of them from England, which is the majority of the population, but also get some from Wales, Northern Ireland, and Scotland. And they take those survey results and swabs on all comers aged 2 years and above. So they get a really good snapshot of how many people are actively infected with and shedding SARS-CoV-2 virus during that period of time. And so just to go back in history and remember what waves the ONS survey has been looking at and looking at the history of UK COVID, again, like us, they had this early wild type virus wave. They had a larger alpha wave than we had there at the end of 2020, beginning of 2021. Then Delta, as we had in the summer of 21, they had less of a huge spike and more of a just prolonged plateau of that. Then Omicron there in December of 21 into the beginning of 2022, and then BA2 wave, BA4-5 wave, and now they're into BQ, and a little bit of the CH is the latest variant in the UK. But you can see deaths occurred, the majority of them in the first two large waves of the original wild type, and then Delta and Alpha. These were all, again, pre-vaccine. And then post-vaccine, they've had kind of a slower burn and accumulation of deaths, but not the giant spikes in the post-vaccine era. And again, because of high rates of vaccination and boosting in the elderly population, they've reduced the number of deaths, but they're now kind of running along at our pace. But if you look at the number of people infected during each of these waves, it gets quite interesting. So you can see early on in pre-alpha and alpha, across all of the age groups, a relatively low proportion of the population, less than 4%, were infected at any given time during these waves, versus now looking at the Omicron era of BA1 and then BA2 and 4-5, where at any given point in time, well, above 6% of many demographic groups in the population were infected, again, at any given point in time. And you can see in Omicron and BA1, over 10% of young adults were infected at the peak. And if you look at terms of cumulative community attack rates among these different population graphics, and this is actually looking at the entire population, you can see that the community attack rates for each of these waves were relatively large and really huge when you get into the Omicron wave. So looking at the initial wave of wild type virus up until the late fall of 2020, only 7% or so of the population of England had been, or the UK had been infected, even though that resulted in a large number of deaths because of the predominance of severe illness in the elderly. Again, in the Alpha era, only about 8% of the population got infected. But now look at Delta and then into BA1 and BA2, you're now getting 25% of the population infected, a full third of the population infected. And for BA2 wave and BA4-5 wave, almost half of the population being infected in each of those waves, right? So massive numbers of people being infected over the last year or a little more. And even though, yes, that has not produced the huge spike in deaths that we saw early because of vaccination protection, and probably some people also had natural immunity acquired from previous infection. What it does mean is you're seeing lots of infections with the risk of long COVID and the other complications that we've seen. When you start breaking this down by age, it becomes even more interesting. You can see that in the early waves of pre-alpha and then alpha, there was relative consistency among middle-aged adults and older in terms of the number of folks infected. You can see over the age of 70 had a lower frequency, again, even though most of the deaths occurred there. And again, we've spoken about the fact that these segments of the population are much less well socially connected, so they don't transmit and just get exposed to the virus as much as younger people. But you can see in the Delta wave, it was really starting to differentiate in terms of younger people were much more likely to get infected. Over 22% of adults 35 to 49 years old were infected during the Delta wave, compared to about 10% of age 70 and older. But then when you get into the later Omicron variants, BA2 and then BA4-5, you can see that the elderly are getting infected just as much. And this is probably a combination of factors, including the fact that boosters are more remote now in the elderly. There are much fewer protections and provisions for disease mitigation now in the UK. Essentially, since early 2022, the UK kind of adopted our strategy of just let it rip. And so without these protections, you can see the entire population is now getting exposed and infected again. When you look at younger populations, it's even more stark, the contrast. Again, looking early, you can see that infection in pre-alpha and alpha was more commonly seen in older children and young adults. Again, that kind of 17 to 24-year-old group seemed to drive that the most. But now look at Delta and into Omicron, it was really school-age children that drove those outbreaks. And over 50% of school-age kids, both in elementary and secondary school age, were infected with Delta. Over 60% of younger kids, as you can see in the top left there in the orange arrow, were infected with Omicron BA1. So it was really kids now that drove the Omicron and transmission for the last year. And again, that's because all of the protections that had been existing in schools, including regular testing, isolation of cases, mask wearing, et cetera, were all taken away when last year when Omicron started. And so letting it rip just meant that it ripped through kids more than adults, because kids are together in schools, and they've been, especially for the late Delta and early Omicron waves, were the unfortunate recipients of most infections. What this also means, there you go, you can see the differences. But what this also means, if you add up for age 2 to 11, the total of infections for each of those waves, you can see that 200% of children have been infected, which obviously means that over the course of all of these waves, just about every child's been infected more than once, and that's certainly not evenly distributed. So there is probably a handful of children who've never been infected, maybe the ones who got really lucky and were vaccinated early. There's certainly a lot of children who had one infection, and so that means there are a number of kids who've had 3, 4, and maybe even 5 infections. So what does that mean in terms of the frequency of long COVID we're going to see in kids, the other long-term health consequences that we know are associated with repeat infections? Hard to say, but I think there's a lot of concerning information out there, including some of the things that we discussed in terms of potentially contributing to the increased severity of influenza and RSV in young kids, and even the outbreak of group A strep that's been quite predominant in the UK over the fall and winter. So what does that mean in terms of cumulative deaths? You can see that over the course of the pandemic, the US and the UK have been somewhat similar. The UK had much higher rates of death, much higher impact in terms of per capita mortality early on in the first couple of waves, but we have had much higher mortality through the Delta and Omicron waves because we had lower rates of vaccination. But now we're relatively mirroring each other as we move into the post-Omicron phase. And what we also see now is where Japan and South Korea, as I've mentioned, two great examples of pandemic management done well, at least for the first couple of years. Now that they've relaxed a lot of their provisions, we're all kind of evening out at this new normal, which is a rate of per capita deaths from COVID that are somewhat similar, at least on the same order of magnitude. Whereas obviously Japan and South Korea had much lower rates early on. But over the course of the pandemic, you can see the US and the UK accumulated tons of deaths early on. And so we got this giant head start. And now that we're paralleling, we're probably just going to grow at a similar rate. And so what this ultimately means is we still have about 6 times the number of COVID deaths per capita that Japan has had, a little less in terms of the difference with South Korea. So that means that this new normal that we've got, that we essentially arrived at by taking away all non-pharmaceutical interventions very early and doing a relatively poor job of getting people vaccinated and boosted, means that we paid for this with over 1 million American lives. So if we had the similar COVID mortality rate of Japan, we would have had about 1 million fewer American deaths than we've had over the course of the pandemic. And obviously that's not counting all of the cases of long COVID, pediatric cases of COVID, and post-COVID health impacts that we are going to unfortunately learn about over the next 5 to 10 years. So this is potentially the new normal. Again, this relatively high rate of cases and decent number of deaths, again, at a pace to be well above 100,000 to 150,000 a year. And right now, it doesn't look as if that trajectory might change anytime soon. So that's all I have. Thanks, Shelley.